I want to welcome you to Nascent Surgical's newest product called the miniSQUAIR. This is a surgical smoke and bioaerosol capture device. We'll now demonstrate removing it from its pouch. The product will consist of the plenum, which had been protected by a small little particle board that is you get rid of that. The tubing is 1 1/4 inch tubing. It's corrugated, at the end of which is a 2-inch plastic adapter, which should fit into any of the male connections on the ULPA filter that you encounter. Now it may happen, and we'll get into this in a moment, that some may not have a male but will rather have a female adapter, i.e. an opening that can also admit the 2-inch spiral adapter. At any rate, let's go back to the plenum. Once the area of the skin has been prepped and dried, perhaps an IABAN drape has been put on, it's now ready to apply the mini. The surgical tech will go up to the top of this, right near the plastic transition adapter. There's a little tab, and he or she will pull it down, remove the release paper, and underneath will be a sticky polyethylene film. This will be attached to the IABAN drape to the patient, or in some cases, the surgeon, especially for the first time around, may suggest just putting it on top of the outer barrier drape. That's up to them. Usually it's put on the side opposite the surgeon. Once in place, and I'm going to just stick it down to the drape. I'm sure it won't go anywhere. At that point, once in position, remove the tapes that hold the 8 feet of sterile tubing in place. If you remove it beforehand, you're going to have 8 feet of sterile tubing flying all over the place, which you don't want. At the end of it are 2 adapters. I mentioned already the 2-inch spiral adapter, but there's also, and you can use a little muscle on this, a proprietary adapter that will fit into most female openings on ULPA filters. But I think you'll find that almost in all cases, this 2-inch adapter will do just fine. Okay, now that's the internal diameter, 2 inches long, but the internal diameter is 25 millimeters, or approximately 7/8 inch hose. I'm sorry, that would be 23 millimeters. Or 7/8 inch internal diameter. And almost all of these ULPA filters come with male adapters that are ready to receive this type of adapter. It takes about 2 seconds to put it on. You're ready to go. That's it. It completes the circuit. In this instructional video, we're going to go through the steps that your surgeons normally take during the course of the operation. So we're going to start with the prep. Now that the prep has been applied and we've allowed it to dry, the next step, as you know, would be to apply squaring it off with towels. We are assuming, for our purposes today, that we're going to do a midline laparotomy incision. After completing squaring off, the next step, and this may not be the case with all your surgeons, but many of them will ask for application of a drape. Now that we've prepped the skin, allowed it to dry, squared off and applied the plastic drape, the next step would be to mark the intended line of incision. In this case, it would be a midline laparotomy incision. The next part would be to introduce the miniSQUAIR with the tapes intact until the plenum is in place. To do that, you pull down on the release paper, exposing the adherent surface. It is then put as close to the incision as the surgeon will allow, should be at least within an inch of the incision. And then after the plenum is in place, then we remove the tapes that hold the tubing. The tubing is then given off the table, placed off the table, given to the circulating nurse, who will then hook it up to the smoke evacuator that is being used. At this point, we're now up to the last part of the procedure, which is the placement of the laparotomy drape. Now, after placement of the miniSQUAIR, as close to the line of incision as possible, the laparotomy drape is put on, and literally put on top of the miniSQUAIR. The racetrack release paper has been removed, and the surgeon would then put the edge of the fenestration immediately close to the cell phone, and you can see by doing so, it almost makes the miniSQUAIR invisible. This would complete the placement. As you can see, we have already prepped and allowed the skin to dry. We then squared off with towels. We will assume that a plastic IABAN sticky drape has already been applied. The next step, therefore, would be to mark the incision. Hips, and by the way, this is for hip surgery, would be either an anterior incision or a more standard lateral incision. Both of them are incisions that you would likely see today. In either case, the miniSQUAIR is placed at the superior margin of the incision. So if it's anterior, it would be over here. If it's more lateral, it would be over here. And of course, in that case, the patient would be straight lateral. This is sort of semi-lateral. Again, the removal and the ability to get this thing, to get the device to stay, you would remove that. I'm going to just put it near the more anterior incision for the time being. And then the laparotomy drape would be placed on top of that. Now the laparotomy drape has been positioned. We've taken off one of the racetrack adhesives, and we're going to put it very close to the edge, but not occluding the edge of the miniSQUAIR. And that's it. We're ready for surgery. All right, let's assume the prep and drape has been done. All the other draping has been done, and we finally have the final laparotomy drape on. The tourniquet is on. All that has been done ahead of time. And the last thing to go on now is going to be the miniSQUAIR. So the first thing that you'll notice is that the incision, I'm presuming, will go right down the center of the knee. The miniSQUAIR, once again, you take off the release paper, and this time we're going to put it right at the top. We're going to put it right at the perpendicular to the top of the incision and push it down on whatever is below, whether it's a drape or what have you. And then we will take off these tapes and throw off the tubing to the side and attach it to the ULPA filter as we usually do, and we're ready to go. This is what it would look like for a knee incision. We will anticipate that the smoke will be able to travel from the lower part of the incision up here. Now, we have tried putting it on the medial side of the knee, but the repetitive flexion and extension over time did tend to separate the layers of the miniSQUAIR. Now, we have reconstructed a firmer type of miniSQUAIR which we will be testing clinically, but right now this is the preferred method of application. Although this is not commonly the way the knees are draped, because they usually drape with these perforation fenestrations, it is possible that a drape could be developed that could in fact cover the miniSQUAIR right up to the edge. But as I understand it, for knee surgery right now, those kinds of drapes are not currently available. I'd like now to show you another alternative positioning for the miniSQUAIR for knee surgery. Now, in a previous video, we've shown the use of the miniSQUAIR perpendicular to the knee incision. But this requires a fairly strong vacuum, which may not be present in your operating room. So let's try an alternative approach. Now, the incision for knee surgery will be across the patella. It will look something like this on the anterior aspect of the knee. The miniSQUAIR, for this particular instance, will be placed along the medial side of the knee. Once again, the release paper is removed, discarded, leaving a very sticky adhesive surface. And the product is quite sticky, as advertised, and is placed on the medial aspect of the knee. The tubing will have, at this point, once applied, you remove the tapes, discard, and then the tubing is discarded toward the foot of the bed, followed by placement of the drape over this. Now, we will presume now that the skin has been prepped and draped, and perhaps a plastic drape, an IABAN drape, has been placed over it. If so, the miniSQUAIR would be placed over the IABAN drape, and now the final draping will take place. Now, I don't know exactly what drape you might be using, but for our purposes, for demonstration, we'll use a laparotomy drape with a central fenestration, a longitudinal one. The racetrack adhesive has been removed, and then we'll place this right at the very edge of the miniSQUAIR. Takes away any distraction that it might otherwise cause from the white color, the white foam, and you're ready to go. Now, you may wonder to yourself whether or not this product will allow you to do the multiple flexion and extension procedures that are part of knee surgery, and the answer is yes. A special construction has been formulated expressly for this kind of flexion extension issue, which can also be beneficial for hip surgery as well. One of the easiest applications for the miniSQUAIR is for lumbosacral spine surgery. In this case, we'll presume that the skin has been prepped and dried, and an IABAN or similar type adhesive plastic drape has been applied to the skin. Over the drape, the incision The line of incision will be marked. And then the miniSQUAIR will have been handed off to the scrub tech. And one can see that there is a tab for the release paper, which is then peeled from the top to the bottom, discarded, exposing a very adhesive layer that you will apply to the IABAN drape, or in some cases just prep dried skin. That's up to the surgeon's protocol. You center it on the incision, put it within an inch of the incision. You can see the adhesive layer really conforms, allows you to conform to the skin, the body contour, and then the tapes are removed. Eight feet of sterile tubing is then handed off to the circulator. The circulator nurse will then attach this plastic nipple to the ULPA filter of the smoke evacuator. We won't see that for our purposes. Once this is done, attention then is drawn to placement of the laparotomy drape. All right, the laparotomy drape is positioned. The fenestration is positioned as well. The racetrack adhesive has been removed and is applied right to the very edge of the miniSQUAIR. And you can see once the fenestration of the drape has been applied to the patient, you can almost see none of the miniSQUAIR. Surgery is now to begin. The procedure is standard mastectomy. We will assume that the skin has been prepped and dried in the usual fashion, after which the intended lines of incision are marked on the skin. And as before, we towel off, square off the towels, apply your laparotomy drape, and then, just as we did for the reduction mammoplasty, with the miniSQUAIR put onto a towel, remembering only over the fold of the towel, not the free edge, so it isn't brought up by suction and occluding the cell foam. You'll then place this in a longitudinal fashion along the midline of the patient and clamp this to the drape, to the laparotomy drape, and proceed with your surgery. As the procedure goes from medial to lateral, the smoke column will be further and further away from the cell foam, so that when you get about 3/4 of the way toward the axilla, you're going to have to reposition this one time about, I would say, midway on the breast, with all the tissue now coming over toward the lateral aspect, and that should be adequate to collect the smoke on the lateral side of the breast. For the purposes of this demonstration, we will assume that the skin has already been prepped and that the prep has been allowed to dry. The next step would be, for a nipple-sparing mastectomy, to make an inframammary fold incision, because the entire mastectomy will be done through that single incision. The next step would be placement of the miniSQUAIR immediately adjacent to that incision. Again, we'll take the release paper off and position it as close to the incision as we can. Pretty sticky. And then again, towel off. So the procedure is really the same, except that with the breastwork, it's probably the one place where we have to have an ability to have a little more variability in the way the miniSQUAIR is positioned. The nipple-sparing mastectomy is probably the easiest because all the work is being done through that incision. So once again, we towel off, and then a laparotomy drape would be put over this. Okay, so at the completion of the prepping and draping, what we really have here, once again, is using the outer surgical barrier drape to pretty well conceal the miniSQUAIR itself. And that's what we've accomplished here. And in the nipple-sparing mastectomy, all the work will be done through this incision, and then the retraction of the skin flap, which will be a major skin flap, will be done in this cephalad direction. Should you have a situation where you have a local excision and an anticipated sentinel node biopsy or axillary node biopsy, in this particular instance, you can almost always place the miniSQUAIR at the superior portion of the breast prior to placing the laparotomy drape, which will, so then we'll do that. Now that we've shown the position that you can keep the miniSQUAIR in for the nipple-sparing mastectomy, how about a reduction mammoplasty? Here, the incision has simply been extended like a hockey stick incision and a circumareolar incision. And once again, we will square off. The prep has been dried as per usual. And unlike before, where we were able to stabilize the miniSQUAIR, here we're going to have to move it from one position to the other. So this is a little different, and this is how we'll do it. But first we have to put the laparotomy drape on. Unlike before, where we could stabilize the miniSQUAIR with its own adhesive, this time we are adhesing it to the towel. And I want you to point out that it has to adhere to the towel not at the free edge, because once you apply suction, that would simply be pulled right over the cell phone. So you fold the towel in such a fashion that you have a free edge that's really going to stay stuck to the bottom. And during the early part of the procedure, all you need to do is to hold it in place, is just hold it with a clamp and then proceed with your surgery. The problem will come as you move this move the surgery to the upper part of the breast, because then the smoke has to travel across the entire field. Most smoke evacuators that are available today are not strong enough to move the smoke 6 to 8 inches across the field. Therefore, you will have to reposition the miniSQUAIR, and that's why we put it on a sterile towel one more time. So after all these skin flaps are developed, the breast tissue is freed up, at that point you can reposition it, again using a clamp to hold it in place. perhaps one on the other side as well. Then the surgeon can follow up. The skin is out here now. The skin flap is up here. And then he or she can continue to do the dissection up above. And now the miniSQUAIR cell foam is close enough that the smoke will travel with the smoke evacuation power that's available today, the shorter distance, and be taken away. So it's two positions. Put it on a towel first. You start at the bottom, position 1, hold it in place with a clamp, and as the procedure continues and you're up to the superior flap, just remove the clamp, reposition it closer, reclamp it to the outer drape, and then you're ready to go. That's the way it's done. We'd now like to demonstrate the positioning of the miniSQUAIR for perianal, but of course this would also work, what I'm about to show you will also work for perineal, perivulvar areas as well. So after the skin is prepped and dried, the miniSQUAIR is taken out of its container. And once again, I want to point out that it can be used just above and placed there, or if you prefer, over on the side. It's really a matter of preference more than anything else. But for our purposes, we'll put it on the side. Once again, the release paper is pulled down from the top to the bottom and discarded. Do not, once again, let me remind you, do not remove the tapes until you place the plenum, because then you've got 8 feet of sterile tubing swinging all over the place, so don't do that. So I would again place it as close to the incision as possible, which should be within about 1 inch. The incision might be something like this. And then after placement, then you can cover it over. After you release the tapes, and the tubing is then handed off to the circulating nurse. And again, this adapter, this 2-inch spiral adapter, is connected to the ULPA filter on the smoke evacuator. Once the miniSQUAIR is in position, the drape is then put over the top. The racetrack adhesive has been removed, and we'll just line up the edge of that right to coincide with the edge of the miniSQUAIR. You won't even know it's there. The operation can now proceed. The name of this procedure would be an abdominoplasty. In this instance, just like reduction mammoplasty and a standard mastectomy, it's going to be necessary to move the miniSQUAIR from one position to the other. So once again, we're going to position it on a towel, along a fold of the towel, as close to the cell foam as possible. Now, in this particular instance, the usual incision is a lower curvilinear incision, depending upon what the plastic surgeon wishes to do. But I would say that's a fairly typical incision. There'll be another one around the umbilicus, but I'm not going to put that down here because that can change once the flaps are developed. So we will once again square off. And because we have to move the miniSQUAIR around, we cannot put it underneath the drape. So the next step would be the laparotomy drape placement. Once the laparotomy drape is in place, in this instance, then the miniSQUAIR will go on top of it. And once again, we'll use a clamp to clamp the towel to the drape, and the surgeon can then proceed. As the dissection continues up and the skin flap is being developed, once again, will have to travel with that surgical procedure. So in order to get close enough to capture the smoke under the developing skin flap, recognizing that we have only limited suction power from available smoke evacuators, we'll just have to move from position 1 to position 2. Once the skin flaps are developed, at that point there'll be additional work that has to be done on the umbilicus. So we'll go back to a lower position and hold it in place with a clamp. Now that the skin has been prepped and the prep is allowed to dry, the next step would be to towel off, just as done previously. And we will assume that we'll be doing a laparotomy incision. But in this instance, we will not be using a drape. Once again, the release paper is taken off of the mini and it's put as close to the line of incision as possible, which would be within about 1 inch from where the cell foam is. And now we'll put the laparotomy drape on. As the drape is put on and the racetrack release paper has been removed, just place the edge of the drape as close to the cell foam as possible, and by so doing you can almost see that it becomes invisible to the surgeon, and of course that's what we want. We don't want it to be something that might distract the surgeon. The next procedure we'd like to demonstrate would be a fan and steel incision. This would be for a gynecologic procedure or an obstetrical, a C-section, for example. So here again, the area is prepped and the prep is allowed to dry. A transverse suprapubic incision is made. Once again, we square off with towels. Now the question is where to put the miniSQUAIR. For the purposes of using Balfour retractors or simply a handheld retractor, which is usually the case with C-sections, we have already removed the release paper. This is the sticky side of it. And you put it right on the top, superior to the incision. Once in place, we then proceed with the laparotomy drape and cover it over. Once the laparotomy drape is applied and placed over the miniSQUAIR, again, I believe it is not a distraction to the surgeon, and yet you can put the miniSQUAIR very close to the line of incision. As you can see, not only do we not have to hold the miniSQUAIR in our hand, but we also have a very low profile, very low, and so it doesn't get in the way of the vision of the surgeon. And you can see just how much surface area we have for smoke capture and how low the height is. It's only about a ½ an inch above, so it doesn't get in the way. You can put in any retractor into these wounds and compress the miniSQUAIR, just so long as you keep at least some of the cell foam surface area available, the smoke will find its way into it. Now, for the mid-sternotomy incision, once again, it's prepped It's draped, and I'm going to assume that an IABAN drape has been put over this. So once the IABAN drape has been put over this, at that point, we are then going to place our miniSQUAIR. We're going to place our miniSQUAIR, usually on the side opposite to the surgeon, which will be on the patient's left-hand side, as close to the midline incision as possible. We'll just mark that. Remember, this has been placed over the IABAN, at which point we then towel off, as we usually do. We have to remember about incisions for the drainage tubes. So that I'll leave up to the surgeon. He may want to angulate this just a little bit if the tubes are to come out over here, but that's not the purpose of this particular training video. At that point, we will then put on the drape, the laparotomy drape. Once the miniSQUAIR is in position, the thing about the open heart cases is that there is so much material around the table that you usually have to use extension tubing. This is an example of the extension tubing that we have. It does include a filter, a pre-filter, but there isn't much difference other than that. The pre-filter, of course, was originally put on to try to protect the usefulness of the ULPA filter, which is a very expensive part of this, of smoke evacuation. At any rate, let's carry this forward toward the foot of the table, because what will happen now is that the circulator nurse who will receive this part of the miniSQUAIR tubing will then attach this to the extension tubing. Doesn't take very long. After the extension tubing has been connected to the end of the miniSQUAIR, and now we may be as much as 10 or 15 feet away from the site of the surgery, the circulator will then come by and hook this up to the ULPA filter. And that, my friends, is an example of what happens when you need additional extension tubing. It will not interfere with the ability to capture the smoke, however. The additional length will not interfere with being able to capture the smoke. So that's the only example that I can think of where extension tubing is uniformly needed because of all the other equipment around the heart surgeon.